Adrenocortical insufficiency. This is also discussing Addison's disease, which results from damage to the adrenal cortex. The damage causes the cortex to produce hormone levels that are too low. We will discuss how the brain and adrenals affect Addison's disease in the presentation. Other causes, however, are tuberculosis, HIV, fungal infections, tumors, and bleeding into the adrenal glands. Pathophysiology primary is that autoimmune destruction which leads to hypofunction of the adrenal cortex. Secondary, adrenocorticotropin hormone, ACTH deficiency could have decreased or absent production by the pituitary gland. Aldosterone is a mineralocorticoid produced by the adrenal gland and could be deficient, and this would affect sodium, potassium, and water uptake. Aldosterone helps with blood pressure, and when this is low, the kidneys cannot regulate sodium and water, and the volume drops. If there is not enough ACTH, then there could be insufficient cortisol. The cortex produces three hormones. Glucocorticoid hormones like cortisol maintain glucose control and suppress the immune response and help the body respond to stress. Mineralocorticoid hormones like aldosterone regulate sodium and potassium balance. The sex hormones like androgens for males and estrogens for females affect sexual development and sex drive. The clinical signs of Addison's. This is a slow destruction of the adrenals. The symptoms do not tend to become evident until about 90% of the adrenal cortex is destroyed, and many times the disease is often advanced before it is diagnosed. Symptoms are slow and lead to muscle weakness and fatigue. Gastrointestinal issues include weight loss from anorexia, nausea, vomiting, and diarrhea. Also, constipation and increased abdominal pain. Mental health includes irritability, depression, and anxiety. The other clinical signs. One way to look at this is that you have 4 hypos and 2 hypers. So we have hypotension, hypoglycemia. They're going to have salt craving, so they're hyponatremic. And then dehydrated due to low volume, so they're hypovolemic. The next one is hyperpigmentation, and that's bronze skin over the joints, creases, and palms. And this darkening of the skin is most visible on scars, skin folds, pressure points like elbows, knees, knuckles, toes, lips, and mucous membranes. And then the last one is hyperkalemia. Diagnostics Addison's disease. This is the most specific test for diagnosing Addison's. In this test, blood and or urine cortisol levels are measured before and after a synthetic form of ACTH is given by injection. The normal response after an injection of ACTH is a rise in blood and urine cortisol levels. In this test, the cortisol is measured in the blood and is repeated 30 to 60 minutes after IV ACTH injection. The ACTH stimulation test would show primary adrenal insufficiency is confirmed when cortisol levels fail to rise over basal levels with an ACTH stimulation test. Diagnostics also would include serum cortisol, serum ACTH, urine cortisol, and aldosterone. On a 24-hour urine study, there would be no increase or minimal increase of the urinary and plasma cortisol with a 17-keto steroid. Urine levels of free cortisol are low, as is the urine level of aldosterone. A positive response to ACTH stimulation test would indicate a functioning adrenal gland and points to a probable diagnosis of secondary adrenocortical insufficiency related to the pituitary gland. The chemistry panel would show a decreased sodium, glucose, increase in calcium, potassium, and the BUN. And the CBC would show anemia and probably an increased lymphocyte count. And the CT and MRI are done to rule out any other issues that might be happening with the patient. Nursing management. This is a circulation problem. They need to give them normal saline and return the sodium and potassium back to normal. If the adrenal glands are not working, then hydrocortisone, which is the most common form use of hormone therapy, because it has both glucocorticoid and mineralocorticoid properties. During stress, the glucocorticoid dosage is increased to prevent an Addisonian crisis. If aldosterone is deficient, then a mineralocorticoid replacement, the fludrocortisone, given daily. Increased sodium needs to be added to the diet. Methylprednisolone may be given if a patient has COPD and heart failure. This mineralocorticoid can help prevent the fluid retention. Symptoms of an Addisonian crisis would include a sudden penetrating pain in their lower back, their abdomen, legs, vomiting, diarrhea, they're dehydrated, low blood pressure, and eventually a loss of consciousness. So an NCLEX question could be, how do you know they're responding to treatment? It's really simple, when they begin to have a coherent discussion with you. So what will kill you? An Addisonian crisis, if left untreated, can be fatal. CT and MRIs are used to identify causes other than autoimmune, including tumors, fungal infections, tuberculosis, or adrenal calcifications. But because Addisonian crisis is life-threatening, it requires aggressive shock management. So treatment should be high-dose hydrocortisone replacement. Large volumes of normal saline and D5W are given to reverse hypotension and electrolyte imbalances because the goal is to get the blood pressure to normal. Assess the vital signs and signs of fluid volume deficit, and if they do get large volumes of fluid, then check for fluid volume excess. Look at what their electrolytes are doing. Monitor their serum glucose, sodium, potassium. Establish baseline data regarding their mental status, especially what their initial vital signs and weight are. Try to get a complete history to determine what drugs that could potentially interact with corticosteroids. That would be drugs like anticoagulants, cardiac glycosides, oral contraceptives, oral hypoglycemics, and nonsteroidals. The main thing is find the underlying cause, that if it's an infection, then they need antibiotics. But it is important to protect the patient from noise and light and environmental temperature like too hot or too cold. The patient will have difficulty coping with these stresses because of their inability to produce corticosteroids. The collaboration teaching for Addison's disease: in order to save your buttocks, you need to add steroids and add sodium. So ASS, add steroids and sodium. Now the daily glucocorticoid, the hydrocortisone replacement, usually would be 2/3 in the morning and then 1/3 the rest of the dose in the late afternoon. If the patient is going to take a mineralocorticoid, then it would be the fludrocortisone and it would be in the morning. A person who has Addison's disease really should carry some kind of identification in case of an emergency, and it would alert emergency personnel that they would need to inject 100 milligrams of cortisol if the person is found really injured or unable to answer questions. So it is important to have an injectable form of cortisol in case of an emergency. A person with Addison's also should know how to increase their medication during periods of stress or mild upper respiratory infections. They would need immediate medical attention if they have severe infections or vomiting or diarrhea, because the infection, vomiting, and diarrhea could precipitate an Addisonian crisis. The severe infections, vomiting, and diarrhea could precipitate an Addisonian crisis. The patient would need to be hospitalized and may require injections of hydrocortisone.